About intraoperative care, we are talking about the care that is happening in the surgery department, and this is divided into 3 different areas or zones. The restricted zone is the actual surgical suite where the procedure takes place. This area will have the most restrictions and require the nurse and staff to be completely dressed out in surgical scrubs with shoe covers, head covers, and mask. Foot traffic should be kept to a minimum to avoid the risk of contamination. The unrestricted zone is the only area where street clothes are allowed. This is typically where we will find the nurse's station, the locker rooms, and the holding area where the patients will wait for surgery. The semi-restricted zone is in between the restricted and unrestricted areas. This area is only for surgical staff in surgical scrubs, complete with shoe covers, head covers, and mask. The operating room itself is of course in the restricted zone and has sterile areas. There are measures in place for the airflow to be controlled and filtered. They actually use positive air pressure to keep the outside air out. They also keep the OR cold and the humidity low to help with sterility. Who is the surgical team? The circulating nurse is the nurse documenting and getting extra supplies. The surgery or scrub tech is the person setting up the sterile field, counting the supplies, and handing supplies to the surgeon. Table 18.1 in your textbook does a really good job of explaining the duties of a circulating RN versus a scrub tech. The surgeon is, of course, the person performing the surgery. The surgeon's assistant can be another surgeon, a physician's assistant, or an RN first assistant. The anesthesia care provider can be an anesthesiologist or a certified RN anesthetist. So that would be a CRNA. And of course, all of these people need to know how to effectively communicate with each other because they are working very closely to care for the patient and maintain sterility. How the patient is positioned during the surgery ultimately depends on the type of procedure. This is very basic, but it's important to provide as much privacy as possible when positioning the patient, just like you would when taking care of a conscious patient. Something else the surgery team has to do is make sure that the patient's airway is maintained and they aren't occluding any vessels that could lead to a pressure ulcer from a lack of blood supply. Another thing to keep in mind is that the patient could experience some kind of trauma or injury from positioning or equipment. This could once again be a pressure ulcer from laying on the equipment, a skin tear, or even just muscle soreness that develops post-op from maintaining a certain position. A timeout must be completed prior to every procedure. When the timeout is called, everyone in the OR stops what they're doing to go over the checklist one more time. So this is one last verification that the right patient is in the OR, that they are about to perform the correct procedure on the correct site, and all pre-orders and paperwork has been completed. The supply count must also be done. This is done prior to starting the surgery and before closing the incision. This is done to make sure nothing gets left inside of the patient. There are a few different anesthesia types, and which one will be used depends on the procedure, the patient's history, and the current condition. With a block, the patient won't lose consciousness. They will just lose sensation to whatever area received the nerve blocks. I've seen this used a lot with diabetic patients who are getting lower extremity wounds debrided. Moderate to deep sedation is the next level up. Sedation is used, but the patient typically maintains some level of consciousness and can usually still follow commands and answer questions. I've only seen this used once at the bedside when they were setting a broken arm back into place. It was a middle school age kid who was actually able to answer questions the entire time. They were just very drowsy and their responses were a little bit slower than usual. The next step up would be MAC. That's your monitored anesthesia care. The patient will be sedated and may even need an artificial airway placed, but this isn't as deep of a sedation as general anesthesia. With general anesthesia, the patient loses all consciousness and sensation and requires an artificial airway to be placed. You really don't need to know a whole lot about the medications that are on this slide, but I do want you to be familiar with them and know that they are often used with surgery patients. Opioids will typically be given for pain. Antiemetics are commonly needed post-op since both anesthesia and opioids have nausea as a side effect. Benzos can be given to help patients with pre-op anxiety, and they can also have an amnesic effect, which could be beneficial as well. And last on this slide is neuromuscular blocking agents, and those will help relax the muscles and keep them paralyzed during the procedure. Here we have some things to consider when the surgery patient is an older adult. One thing we know is that body organs don't always work as good as they once did when patients age. So because of this, we have to give lower dosages of medication to prevent accidental overdosing. If the patient's liver and kidneys are filtering at a slower rate, it's going to take them longer to process, break down, and excrete medications. We also worry more about pressure injuries due to the changes in skin and circulation. We also worry about hypothermia because older patients tend to have more difficulty regulating their temperature. And we do expect a natural drop in temperature to occur because of an effect of the anesthesia and the OR just being kept so cool to decrease the bacteria count. And last on this slide, we worry about pain. We want to make sure we are doing good pain assessments and possibly even using the face pain rating scale because older adults sometimes tend to underreport pain. And a lot of older adults, especially the ones with chronic pain, sometimes just assume pain is a natural part of aging. On the opposite end of this, we want to closely monitor for side effects if they are receiving opioids. We know that opioids can decrease the blood pressure and the respiratory drive, so we want to keep a close eye on those vital signs. You'll also want to monitor bowel sounds and I&Os. Opioids can slow down the gut and cause constipation, so you want to make sure that you are encouraging liquid intake, early ambulation, and maybe even asking the doctor to order a stool softener. Here we'll talk about two different crisis events, anaphylactic reactions and malignant hyperthermia. Anaphylactic reactions are something you should already be familiar with. We know that they are life-threatening and involve pulmonary and circulatory complications. This is when your patient would report that they feel like their throat is closing up. And with this, we'll also see a drop in blood pressure, a rise in heart rate, bronchospasms, and pulmonary edema. In the healthcare setting, we worry about this a lot with latex products. We know that anaphylaxis is very, very common with latex allergies, and many medical products are made with latex. So as a reminder, if your patient reports an allergy to bananas, avocados, or strawberries, you should be clued in that they may also have a latex allergy because those foods share some of the same proteins as latex. Malignant hyperthermia happens as an adverse reaction to anesthesia. On assessment with this, you would see a very high temperature, a high heart rate, a high respiratory rate, and very rigid skeletal muscles. We treat this by treating the fever and giving skeletal muscle relaxants. So, however, if this goes untreated, it can result in cardiac arrest and death. So early assessment is very crucial. We know not everything has to be a major surgery, and there are some benefits to that. So we see those benefits of minimally invasive surgeries. And with these, we can expect less blood loss because there isn't a huge incision. If there is an incision, it's usually very small, but sometimes only puncture sites are used. And these patients usually experience less pain, have a much quicker recovery, and a shorter hospital stay.